All right. Good afternoon, everyone. My name is Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joseph Healthcare Hamilton, and we're pleased to be hosting citywide medical grand rounds today. We'll start with a land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. And so it's my pleasure to welcome our presenter today. We have Dr. Vikas Tandon, who's presenting on the topic of cardiac PET and its utility in cardiac risk stratification. And I'll start with a bit of a more detailed introduction to Dr. Tandon. He is an associate professor within the Division of Cardiology in the Department of Medicine, as well as an associate professor in the newly formed McMaster Division of Perioperative Care, which is part of the Department of Health Research Methods, Evidence, and Impact at McMaster. Dr. Tandon has been on staff since July 2011. He is the program director of the Perioperative Vascular Medicine Training Program at McMaster and is also the clinical site lead for cardiology at St. Joseph's Healthcare Hamilton. His clinical, educational, and research interests lie in the areas of perioperative medicine, cardiac risk stratification, and cardiac imaging. So Dr. Tandon is highly qualified and an excellent educator, and we're really pleased to have him here joining us today. I'll just highlight, usually I have the head of service joining me to co-host, but since Dr. Tandon is the head of service, I did the introduction, and over to you, Vikas. Thank you so much.
That's great, Madeline. Thank you so much for having me present today, and a warm hello to everyone, and looking forward to presenting and hearing everyone's thoughts and comments as well. So my topic today is looking at cardiac risk stratification, and no industry conflicts with this. And I did do a 2-year fellowship in cardiac imaging at the Ottawa Heart Institute, and so that is where the background in risk stratification comes from. And my initial title was cardiac PET and its utility in cardiac risk stratification. I do want to give a shout out to Dr. Workington, who very astutely pointed out in the initial email a misprint in my title, specifically the apostrophe on its. So its with an apostrophe is a contraction for it is or it has. And when specifying belonging, you want to have ITS without the apostrophe. So huge thanks to Dr. Workington for pointing that out and also keeping us all on track throughout the years. So I went back and as I was debating in terms of looking at the title, I felt, you know what, we should actually think even broader. So I retitled the talk as Nuclear Imaging and its Utility in Cardiac Risk Stratification. And so hence the objectives here will be to look at the basics of nuclear myocardial perfusion imaging, understand the clinical indications and appropriateness for MPI as to when to use this as a risk stratification modality, comparison between our traditional modalities, so MIBI or SPECT versus the new kid on the block, PET, and its use in cardiac testing, to develop an approach to test selection, and then understand the results and implications. So to start off with, what is myocardial perfusion imaging? So myocardial perfusion imaging is a nuclear medicine technique using radionuclides to image the myocardium both at rest and on stress. The rest and stress images are compared to assess the degree of ischemia. And so what's a radionuclide? Basically, a radionuclide is a radioactive atom. And so what that means is that you have if we think back to grade 12 physics, you have your basic structure of the atom with a core nucleus of neutrons and protons. And this nucleus is rearranging itself to get into the most stable configuration. And to do that, it either gives off energy in the form of gamma rays, or in the case of PET, gives off a particle, which is known as a positron. And what that allows to do, the nucleus to do, is to rearrange itself so that it's in the most stable configuration. Because the energy or the particle is coming from the nucleus of the atom, hence the name of the specialty nuclear imaging. We're using products from the nucleus. And so what happens is the radionuclide, in the case of MIB-E, is injected into the patient, circulates through the body, and then gets taken up into the myocardium. And in the case of MIB-E, this gets taken up into the mitochondria of the cells. And from there, because those atoms are giving off energy, what happens is the patient's placed in the camera, and the gamma rays basically are emitted from the myocardium, and they hit the camera plates. And it's from these camera plates that our images are generated. So this is a form of emission imaging. The energy comes from out of the myocardium, so the patient themselves are the source. This is in contrast to many of our tests in the Department of Radiology, so X-rays and CTs, which are forms of transmission imaging, meaning that the radiation, i.e. X-rays, are actually going through the patient. But here, the patient themselves are the source, and the patient is giving off the gamma rays. And we take two sets of images, as mentioned, both at rest and on stress, and we compare to see what the blood flow is like, and then thus assess the degree of ischemia. Because this is emission imaging, so this is how our cameras are named. So SPECT camera stands for single photon emission computed tomography, and PET stands for positron emission tomography. For MIB-E, we are using technetium, which is element number 43 in the periodic table. It's been years since we've seen this. As well as for PET, we're using a molecule called rubidium, which sits in the first column. You can see it sits under sodium and potassium, so it actually uses the sodium-potassium pump to get into the cells. And we'll talk more about rubidium when we talk about PET. So when we're ordering a MIB-E, the term MIB-E actually refers to the molecule. We often think that MIB-E means the test itself or the whole process of imaging the patient. MIB-E is actually the technetium, which is produced in the radiopharmaceutical lab with 6 ligands. And so SESTA, meaning 6, is how this molecule is labeled. So SESTA MIB-E is what's being ordered. So when you're saying we want to order a MIB-E, what the lab is actually saying is that they're actually ordering the radioisotope in this format. And when we're ordering the test, we're actually ordering a myocardial perfusion study. So how does perfusion imaging work? And so basically, as I mentioned, we take two sets of images. At the bottom, I have in the schema labeled rest and stress. On the rest side, basically, what happens is that the radioisotopes, which are indicated here by the 4 diamonds, are injected through, and they distribute throughout the arteries and then get taken up by the myocardium. Even if there's a stenosis, the arteries have a regulation method called autoregulation, which allows them to mildly dilate to allow for that perfusion to occur. So at rest, most arteries can actually accommodate and allow for a balanced flow between both sides. On stress, and stress can be induced either by exercise or pharmacologically, what we're actually doing is we're causing vasodilatation. And because one side is actually stenosed, it's not actually able to dilate as much as the normal side should. And so thereby we create a steal phenomena. And so you can see I'm indicating the steal phenomenon by showing 4 nuclear particles on the left side and only 2 on the right. And as such, when it gets taken up by the myocardium, that area ends up being dim. And the area that has nuclear molecules ends up being bright. And so this is how the concept of ischemia is judged. So it's relative perfusion differences within the myocardium. So this is an example of what we see in the lab when we do the studies. Now, each line represents some element of the myocardium. And so, and these are all paired. So in twos. So the top line is your stress line. The second line is rest, and it alternates. So stress, rest, stress, rest, and each of them are paired. At the top, what you have is our short axis views. So if you picture the myocardium like a loaf of bread, the end piece of that loaf of bread is the apex that we see here, this kind of image that looks a bit like a Timbit in the first three squares. As you get higher and higher into the base of the heart, you start seeing nice round donuts with the cavity, the ventricular cavity in the middle. And so you compare the stress myocardium and you compare that to the rest. If they look the same and they all lights up completely, then you know that there's no ischemia. If, however, such as on this image, you see a bite taken out of the donut on the stress image, but it seems to fill in on rest, that is indicative of ischemia. And that is really how we judge ischemia on these tests. And so this patient, we can see that there's a bite taken at the top of the heart here, as well as towards the apex. So this patient is a patient who, when they were advanced for CAS, ended up having LAD disease. And you can see the image, the CAS image on the right, has basically actually a total occlusion of the LAD. This patient actually also had other disease as well. So the image on the left here is showing RCA disease. You can see it's kind of a raggedy artery there. And so when we look at our operating characteristics in terms of its ability to pick up ischemia, perfusion actually has excellent sensitivity, with it being 87% on exercise, 89% on pharmacological stress. Where we lose out for MIBI is that the specificity is on the lower side, 73 and 75%. And if we think of how the test is done, we can understand why the specificity is a little bit lower. And as we mentioned, that how the test is done is that the radionucleotides, the radioisotope, is actually injected into the patient. It's taken up by the myocardium. But before it actually hits the camera, it needs to get out of the myocardium, the photons. They need to get through all the soft tissue, and then they need to hit the camera plate. And like everything, there will be a percentage of those photons that actually get absorbed by the soft tissue. And so if those photons don't hit the camera plate, the image that gets created has what's called a defect or a dim area where those photons should have been. And so this is the reason why we often see the comments on the reports, inferior diaphragm attenuation artifact, soft tissue attenuation. That's really what that means, is that the photon was not able to actually get out of the soft tissue and hit the camera to register an image. So in terms of our choices of testing and how we do this type of test, as I mentioned, we can either stress using exercise or pharmacological modalities. And the types of cameras and agents are continuously evolving. So technetium-based tracers, so Sestamibi or BioView, have been the mainstay of what we use in our lab here in Hamilton at Hamilton General. At St. Joe's, we have a PET camera, so we're using rubidium. When the Chalk River reactor was down or being maintained, in those times we used a very old tracer called thallium. And there's ongoing research in terms of looking at labeled fluorinated agents, which actually produce almost spectacular images to the point where you can actually even see papillary muscles on these image sets. And so there can be a lot of questions that come up in terms of how do we choose a test. The biggest factor in terms of us choosing a test for risk stratification is actually pretest probability. And so going through this with the trainees, the two examples that I bring up is that 75-year-old male shoveling snow with ongoing chest pain, they have a positive troponin and they have ECG changes, that patient's pretest probability is so high. In fact, you've actually made your diagnosis clinically. You don't need a diagnostic test in the sense of stress testing. You need a therapeutic test. They need to actually go to the lab. Similarly, a young person in their 20s doing heavy lifting and has possibly what sounds like MSK chest discomfort. In fact, that patient, the pretest probability is so low, in fact, you could probably get away without actually doing a test. And in fact, we often forget that physical examination itself is a test, right? You palpate the chest and you're able to induce that chest pain. You're pretty sure that that is MSK chest pain. So those types of patients actually don't need any sort of testing. For our intermediate group of patients, the term intermediate within medicine and cardiology in the perspective of chest discomfort and evaluation of shortness of breath has a very wide range, so 10 to 90%. When the range is so wide, it's often easier to divide this into a low intermediate and a high intermediate group. So my low intermediate patients, these are patients where in my mind, I think this patient probably does not have coronary disease. So these are your young patients. They may have multiple visits to the emerge because of chest discomfort. Tropes continue to be negative. No ECG changes. But because there's a persistence there that, I have symptoms, these patients do come back and so thus do require some sort of risk stratification. In those patients, even a simple treadmill is sufficient in terms of helping doing that risk stratification and conveying a degree of reassurance to that patient. Where patients have significant risk factors, such as diabetes, hypertension, smoking history, or if the plain treadmill is abnormal or inconclusive, this is where perfusion imaging plays its big role in terms of helping to discern that is the patient normal and nothing further needs to be done, or in fact, do we actually need to advance for coronary angiography? When we're doing perfusion testing, your choices in terms of how to stress are divided into exercise and pharmacological. And so the next question that comes up is, what's the patient's ability to exercise? If the patient can exercise, then there is a significant benefit in choosing exercise perfusion as your first line choice. And we do have data that factors such as exercise duration, production of symptoms, heart rate response and recovery, blood pressure response, the ECG response to the stress, or induction of arrhythmias all confer varying levels of concern or reassurance, depending on what the result is. So exercise is the preferred mode of testing for a number of the physiological factors that can be produced from it. And there is data to show that exercise capacity does correlate in terms of long-term outcomes for patients. This is a study from the New England looking at exercise capacity and mortality. And we can see that whether you look at either normal subjects or patients with cardiovascular disease, those who are able to exercise greater than 8 METs actually have better survivability compared to those who are fairly sedentary and their exercise capacity is less than 5 METs. And just so that everyone has an understanding of the concept of METs, so MET is a metabolic equivalent. It's basically a measure of the energy usage at rest. And how we quantify that is actually based on oxygen utilization. So at rest, the basal metabolic rate of usage is 3.5 milliliters of oxygen per minute per kilogram of tissue. So someone who can do 10 METs, what that indicates is that they're actually able to increase their oxygen utility and thereby your energy usage tenfold. At rest, so the concept here of 5 mets here in this graph, or less than 5 mets, that correlates with stage 1 of the Bruce protocol. So stage 1 of the Bruce protocol, for those who have done it, is awfully slow, 1.7 miles per hour. And so it's a very, very slow rate of movement, and that correlates with 4.7 mets. And it's for this reason that using the concept of 4 mets in the perioperative realm really doesn't give us very much information, in that saying someone has done 4 mets and is clear for surgery, really 4 mets, when you actually understand that it's only 1.7 miles per hour, really tells you it's just really the bare minimum. And so in the perioperative guidelines, we've actually moved away from using the concept of 4 mets to clear people for surgery, and in fact move more towards biochemical testing measures such as BNP, which is strata for another talk later on. Coming back to survival and exercise, so JAMA also showed a very similar result in 2003 in females, that survivability definitely is correlated with your ability to exercise, and those who are active and good functional capacity have better longevity than those who are not. So when should we use persantin? So inability to exercise, or if there's any contraindications to exercise. So AAA is the classic example, right? You don't want to increase the shear stress in the aorta in this case. And so persantin is a good choice. Patients with left bundle or paced rhythm, again, if you're not able to interpret the ECG, then you should go with pharmacological stress. And if patients are on medications which will preclude their ability to increase their heart rate, those also are patients that should go with persantin stress. Now, how persantin works, persantin actually potentiates adenosine. And so typically when we think of adenosine, we think of SVT. And to break an SVT, we give adenosine. What actually happens is the adenosine binds to the A1, so adenosine 1 receptor, which is in the AV node, and that's how those SVTs break. But what we often forget is there's actually adenosine receptors elsewhere as well, particularly, and we're making use of the fact that the A2 receptors are in the coronaries. And so this allows for coronary dilatation. When we look at other areas where the adenosine receptors are located, it helps us understand the contraindications to persantin and adenosine testing. So there are adenosine receptors in the bronchioles. And so this is why asthma, severe asthma is a contraindication for persantin. And then the adenosine receptor does play a role in mast cell degranulation as well as angiogenesis. And so those with any issues from angioedema, those patients are also contraindicated for persantin. And so when we go to the list of contraindications, as mentioned, severe asthma, baseline hypotension. So if you're already low blood pressure, you don't want to give an agent that's going to dilate you even further. Similarly, if you're already bradycardic at baseline, you don't want to give medication that can potentially slow down the AV node even further, and hence high degree AV block, sick sinus syndrome. These are all contraindicated. Exposure to xanthines or caffeine intake in the last 24 hours, not necessarily a contraindication from something bad happening, but a contraindication in the sense that the test will not work. And to understand that, we can look at how what is the interaction between caffeine and the adenosine receptor. So this is a rather complicated slide, but the areas to focus on is the center here, where you have this red particle and this yellow particle. The yellow particle actually represents a xanthine analog, so or derivative. So caffeine, theophylline, aminophylline, these are all related to xanthines, and these are competitive inhibitors of the adenosine receptor. And so if the patient has had coffee in the last 24 hours or anything with caffeine, In fact, when you do their stress test, it's actually not going to work. You're just not going to dilate. And so in your mind, you're thinking, oh, I have stress images and rest images. In fact, what you actually have are a rest image and a rest image. So you have two rest images. You haven't actually stressed the patient adequately. And so this is the reason why when ordering a MIBI, the first instruction to the patients are make sure that you don't have any caffeinated products in the 24 hours preceding the test. So no coffee, no tea, no chocolate, no Tylenol 3s. And so this is the reason why caffeine is held the 24 hours prior. So going back again, how does the perfusion imaging work? So again, we talked about creating the steal phenomena. And so there's a relative difference in the flow between the diseased side versus the normal side. And so, as mentioned, the reason why this is useful is that coronaries do function with autoregulation. So arteries in the heart, arteries in the brain, basically up to a certain point, they're actually able to dilate and accommodate, even if they are diseased, up to a certain point. And then after a certain point, they no longer can function normally and they no longer can dilate. And that point seems to be roughly about 70%. So if we look on this graph, we can see that there is a variance in that artery on stress. But for the most part, it's maintained within that flow is maintained within a certain range up until 70%, and then you start seeing a rapid drop off. This 70% is the reason why in the cath lab, patients are with stenoses of 70% are stented, right? And so we do have physiological evidence to support that 70% mark in terms of why we stent at 70%. It's because this is where the vessel can no longer autoregulate to maintain perfusion. And so we've done our test. We have a result which may be normal or may demonstrate a degree of ischemia. For the symptomatic patient, in general, this is roughly how we can look at further management. So if there's moderate to large ischemia in a symptomatic patient, we're going to advance those folks to coronary angiography with view to revascularization. In the symptomatic patient with no ischemia, no previously known disease, this tells us that, hey, the symptoms may actually not be related to coronary disease. We should actually consider other things on our differential. In a patient with known previous coronary disease, if, however, we find minimal ischemia, mild ischemia, small areas of ischemia, one can actually safely consider medical therapy and aggressive risk factor modification. And where this comes from is a study from 2003, which indicates to us that that point where in a patient with known coronary disease, the amount of ischemia required for patients to benefit from revascularization seems to be greater than 10% of the total myocardium. So in our reports, less than 10% is considered small, but greater than 10%, so 10 to 20% is considered moderate, and greater than 20% is considered a large area of ischemia. So that 10% mark seems to be where there's a crossover in hazard between medical therapy and revascularization, with patients in the lower end, so less than 10% ischemia, being better suited for medical therapy, and patients in the larger side being better suited for revascularization simply because the risk of recurrent event in the future is higher than the risk of the revascularization based on current risks associated with CAT. And that is for patients with new symptoms in the setting of known coronary artery disease. So now we get back to the original title of our talk, looking at PET and how does PET fit in, and where does PET and maybe or SPECT kind of cross over in terms of their usage. So as mentioned, we are injecting tiny amounts of radiation to gain our images. And those particles that we inject, depending on what we inject, are either giving off energy, as is in the case of sestamibbe or technetium, or a particle, as is in the case of rubidium. When we inject sestamibbe or technetium, the energy that's associated with technetium, so what the amount of energy that's released to produce our images is 0.140 mega electron volts, or 140 kilo electron volts. So the number itself is not as important as simply understanding relatively the concept of kilo electron volts. So that is how we're measuring the amount of energy. And the comparison to how much energy is given from PET. So everyone can keep the number 140 kilo electron volts for MIBI in their mind. When we look at PET, which uses rubidium, as we've mentioned, rubidium and PET involves, in this case, the release of a particle called a positron. And so if we think back to the Bohr model of the atom, so back to grade 12, right, we have neutrons and protons, which all remain within the nucleus of the atom. But this nucleus sits in a sea of electrons that are constantly orbiting the nucleus of the atom. And so when you release a positron, or a positive electron, is essentially what a positron is, into a sea of negative electrons, basically you have a positive particle and a negative particle, and based on previous laws of physics, those two particles are going to attract. And this is not any simple attraction. This is attraction that happens at the speed of light. So picture two particles traveling at the speed of light and aimed directly at each other. And so what happens is what's called an annihilation reaction. So this is exactly where we've heard the formula E equals mc squared. But it wasn't until I actually started doing PET that I actually realized what that meant. So E equals mc squared. So E is energy, and it's related to the mass traveling at the speed of light, mc squared. So two particles traveling at the speed of light, and when they collide, they essentially annihilate themselves. And so the mass of those two particles gets converted into energy. And that energy are two photons, and this is where the number becomes important. Two photons, which each bear an energy of 0.511 or 511 kilo electron volts, right? So you have two photons at 511. So the total energy here is somewhere in the range of 1,000 kilo electron volts. And so now that we know those numbers, we can actually go back and compare. So a MIBI releases 140 kilo electron volts. In a PET scan using rubidium, we have 1,000 kilo electron volts. So this is like using a 10-watt light bulb and a 100-watt light bulb. So your images are going to be super bright. And so any issues in terms of attenuation, they essentially melt away because you have such better image quality. Your sensitivity is better, your specificity is better, you have superior spatial resolution. So your spatial resolution is 6 to 8 millimeters compared to 10 to 15 millimeters on MIBI. And so any issues that you have with attenuation essentially are essentially almost non-existent in PET. And this is how a PET image looks like. You can see that the image quality is much sharper compared to the previous MIBI images, which I had shown earlier on. And this allows for a higher level of certainty in terms of making your diagnosis. And so when we look at sensitivity and specificity, recall when we were talking about MIBI, the sensitivity and specificity of MIBI was not bad, 87 to 89%, but the specificity of MIBI was in the 70s. Here, we have a sensitivity pooled of about 90% and a specificity also of about 90%. And the reason is that those photons, because they're tenfold higher in terms of energy, actually get through the soft tissue much easier and actually are able to register an image when they hit the camera plate. The other things that the PET camera is linked with is assessment of coronary calcification. So every PET scan has a CT component that is done. And so not only do you get functional imaging in terms of is there or is there not ischemia, but you can actually have some sort of assessment of anatomic imaging, knowing that, hey, there's actually coronary calcification present in that same territory. This further confirms that you're on the right track in terms of coronary disease and ischemia. Other advantages here. So my advantage number 3, significantly less radiation exposure. Now, this sounds a bit counterintuitive because one would ask that, well, I'm using a photon that's tenfold brighter than a MIBI, but then how am I getting less radiation exposure? And the key here is in the half-life of the radiotracer. So MIBI, the half-life of MIBI is 6 hours, which means that 4.5 half-lives is roughly 24 hours. And so it takes 24 hours for the MIBI molecules to completely dissipate out of the system. And thus, while they're in the system, they're still giving small doses of radiation throughout that 24-hour period. The half-life of rubidium, however, is 76 seconds, meaning 4.5 half-lives is roughly 5 minutes. And so this is how we're actually able to put the patient in the camera, give them the rubidium, get a big flash of energy, which produces beautiful pictures. And within 5 minutes, that radiation is out. And so essentially the advent of PET cuts down your radiation exposure to roughly 1/3 what it would have been with MIBI. Talking about radiation exposure here, in general, let's talk about MIBI scans. So MIBI scans are associated with roughly a radiation level of what's called 8 to 10 millisieverts. The cancer risk, lifetime cancer risk associated with this, assuming that 1 in 4 people in the world will eventually at some point in their life have a cancer, that cancer risk goes from 25% to 25.1%. So the overall risk associated with MIBI to begin with is relatively low in the properly selected patient. And I indicate the appropriately selected patient because you want to select patients who are at significant coronary vascular risk, where their coronary risk outweighs whatever their cancer risk is. And so this is why young patients, we should do our best to avoid sending them to radiation-related scans, whether that's CT scans or whether that's nuclear scans, because those young patients have a lifetime to go. They come in with atypical chest pain once, they may come in with migraines the next time, they may come with atypical abdominal pain. And successively, what happens over time, let's order a CT head, let's order a CT abdo. And so over time, radiation doses do accumulate. In patients that we're looking at from a cardiovascular standpoint, most of these patients tend to be in their higher ages, so 50 to 60 plus patients. And so for them, their cardiovascular risk outweighs the malignancy risk at that point. And so it is reasonable to do your risk stratification from that standpoint. So coming back to PET, advantages are better sensitivity and specificity. You do get some anatomic information. In the scheme of different nuclear tests, this basically cuts down your radiation to 1/3. And in fact, the question of balanced ischemia is actually solved with PET in the fact that PET not only gives relative imaging, but can actually calculate the coronary blood flow in milliliters per minute per gram of myocardium. And so if the global flow is down, that will tell you that this patient has balanced ischemia. So there are a number of advantages of PET over MIBI. However, some of our actually, before I get to the disadvantages, this is an image of the non-contrast CT that comes with a PET. You can see anything that's calcified is white, so ribs, sternum, there's some calcium in the aorta here. And here, this is the RCA that has calcification there. So if this patient was to have ischemia in the RCA territory, we would know that, that fits with coronary disease in the RCA. If the patient had normal perfusion in the RCA, that would tell us there's mild non-obstructive plaque in the RCA. So the combination, we are heading towards an era of hybrid imaging and fusion imaging where we get both functional and anatomic components together. In terms of disadvantages, so a PET camera costs roughly twice the cost of a SPECT camera. So where you can get a used SPECT camera for roughly $750,000 to $1 million, a PET camera will cost roughly $2 million. In Ontario, PET cameras are controlled by Cancer Care Ontario because of the very specific oncological usage of PET cameras. However, if there is a PET camera that is at a site where there is a cardiology service, we are permitted to actually piggyback the cardiac program with the oncology program. And so our collaboration with our colleagues in nuclear medicine has been excellent. And so we do cardiac PET at St. Joe's on Tuesdays, Wednesdays, and Thursdays. So time slots are 7:30 to 1 p.m. In the afternoons on those days, we go back to oncology, and all the other days we go to oncology. So it has been an excellent collaboration, and we're very lucky that we have a camera here in Hamilton. We are one of 3 cardiac PET programs in all of Ontario, so the other 2 being Toronto and Ottawa Heart Institute. And so that brings us to the question of availability, that you have a wonderful technology, but I can't access it. And so where this brings us to is to be selective in terms of how we choose our testing. And so, as mentioned at the beginning, for the vast majority of patients, MIBI will still be the test of choice, particularly if you want exercise perfusion, because PET, given how short the half-life is, you actually can't exercise that patient. In fact, the patient needs to be in the camera at the time that the tracer is administered. And so this by default lends itself to pharmacological stress. So if you want the exercise perfusion study, you will by default be choosing MIBI. If you choose persantin for whatever reason, then your next question is, okay, do I choose MIBI or PET? And I think the best way to ration the resources is to look at the BMI. So if the BMI of the patient is 35 and above, cardiac PET is an excellent choice. As mentioned, these are higher energy photons that will give you good quality imaging without the issues in terms of attenuation. If the BMI is less than 35, then those patients can continue on with a persantin or exercise MIBI. So that is really the best way to utilize PET. This talk was focused mainly on risk stratification, i.e., is there coronary disease or not? PET has a number of other uses, which I won't, I don't have any slides for, but I'll just mention very quickly. In the cases of endocarditis, someone has a bioprosthetic valve, we can use cardiac PET to see if the aortic valve or mitral valve annulus lights up for inflammation. In questions of amyloid or sarcoid, we can use PET to see if there is infiltration into the myocardium. And then the question of viability. So if you have someone with a low EF, so de novo heart failure and multivessel disease, and the question is it worthwhile to revascularize or not? Cardiac PET is a wonderful choice for those modalities as well. So in conclusion, nuclear perfusion plays a key role in the risk stratification of intermediate risk patients. Currently, standard imaging techniques such as MIBI are used for the vast majority of patients. New techniques such as PET can have wonderful sensitivity and specificity, And in terms of rationing, we can use them for higher risk patients and patients with increased BMI greater than 35. And that's about it. Happy to take comments and questions.
Wonderful. Thank you very much, Vikas. That was an excellent presentation that took us right from the science principles on through to really practical clinical application. So I appreciate it. And I have to say, I haven't been thinking about atoms or positrons or the periodic table in quite some time. So a good refresher on some of those things. So I would welcome anyone who has questions. We have two main ways to bring forward your questions for Dr. Tandon. You may enter the question into the Q&A feature on Zoom, or for those who prefer to ask the question verbally, you can raise your hand and then we'll put you in the queue and invite you to speak as it becomes your turn. So with that, I'll just turn our attention over to the Q&A, where we've got a question from Dr. Jeremy Adams, who says, great talk, Vic. A couple of questions. Number one, how would you define severe asthma when considering possible contraindications to Brusantine? So maybe we'll start there and then we can do question two.
Absolutely. Thanks, Jeremy, for the questions and the comments. So severe asthma. So when we're in the lab, the key question that we're asking is, have you ever been hospitalized for your asthma? Have you ever been intubated for your asthma? So those are the two key questions that we ask. Mild asthma. So, I take my puffer sometimes. I've never been to a hospital for my asthma. I've never needed to be intubated for my asthma. What we do is we actually do our physical exam in the lab. So I just listen to their chest. If their chest is clear on the day of their test, then we actually go ahead and administer Brusantine, knowing that we have Ventolin in the lab and the patient has their medications if needed as well. Generally, most patients have done well with that technique. So really the question is hospitalization for asthma or intubation for asthma. And the other part of that is clarification. That is, do they actually have true asthma or not? Because there are patients that come and say, oh, I have asthma. But when you actually look at the chart, it turns out that they've had a smoking history and COPD. So if it's COPD, those patients are very reasonable to give Brusantine to respond. In terms of specific populations, so I think this is a great question.
Just so you know, because the audience might not be able to see the question, so I can read it out if you like.
Sure, absolutely.
So Dr. Adams' second question, are there specific populations of patients where PET may hold significant value, e.g. MINS, dialysis patients, transplant assessment?
Sounds good. So yeah, so I think that question lends itself very nicely into the higher risk category that I alluded to in the last statement of the conclusion. So reserving PET for patients who are high risk. So Jeremy Adams and the nephrology group have done a lot of work in terms of risk stratification for renal transplant patients. By default, the vast majority of these patients have underlying coronary disease and have risk factors, including smoking and diabetes. So PET is an excellent modality for this high-risk group, given its characteristics of high sensitivity and specificity, as well as physiological parameters such as what is the coronary flow, what is the response to the ejection fraction at peak stress. And so PET from that standpoint gives various aspects of physiology which may help us understand what the patient's response will be to a stress such as surgery. And similarly, MINS patients, so patients who've had troponin elevations post-op, this also is another high-risk group, which we're doing a lot of work on in terms of research. David Conan, one of our cardiologists, is doing a study called PET MINS, where patients with post-op troponin elevations, when they come to the lab, we have started a PET MINS registry to look at how much ischemia is present, the severity of the ischemia, and what happens downstream to these patients. Phil Joseph, who's one of the cardiologists citywide, did a similar study called SPECT MINS, where we used MIBI to quantify degrees of ischemia in post-op troponin patients, we found that roughly 40 to 50% of those scans had evidence of ischemia. So high numbers indicating that, hey, you know what, this is a population that we definitely need to screen, risk stratify, and make sure we treat aggressively. So good questions. Thank you.
Thank you. Fantastic question and response. So we've got a number of other questions coming in here, 4 more at the moment. The next one, thank you so much. How would you decide between a dobutamine stress echo versus a Persantine MIBI?
I think that's a great question. So in the talk, I alluded to the pretest probability of the patient. So if an intermediate pretest probability is a wide range, so 10 to 90%, it's easier to break that down into a low intermediate, kind of 10 to 50% range, and a high intermediate, 50 to 90% range. My high intermediate patients are my diabetics, my long-term smokers, my patients with previous coronary artery disease, stroke or peripheral arterial disease, my CKD patients, my rheumatology patients. Those all fit into my high-risk group. And so those patients, I think, lend themselves very well to perfusion, so Persantine MIBI or PET. My low-risk group, so my younger patients, my patients aged 35 to 50, where they're so young that I don't want to actually expose them to radiation. That group of patient, I think, lends itself very well to dobutamine stress, because dobutamine stress does not have any radiation exposure. It's based on ultrasound. Your likelihood of having disease is low. So in dobutamine stress, the issue with dobutamine stress is its sensitivity sits at about 80%. So you're not getting that 89 to 90% sensitivity, but you're selecting a lower risk population to begin with. And so you accept that, hey, you know what, this is reasonable for this low risk population. So that's how I would stratify.
That's excellent. What great advice. We have another question here from Dr. Serena Gundy. Hi, thanks for this practical and helpful talk. So on that note of availability and utility, I have a request related to the patients I see in a different context. Post-eclampsia with trope elevations for longer-term risk stratification. Happy to wait to the end or ask offline, as this is a side question and not globally relevant to all, but I think maternal health is super relevant. So, let's take a moment to get your input here, Vikas.
Absolutely, absolutely. No, thanks, Serena, for the question. I think actually the question fits in quite nicely to the previous question in terms of dobutamine stress versus MIBI. Generally, when we're talking about maternal health, we are talking about a younger patient population. And so, dobutamine stress echo is actually a really good test in that population group, because you can give them dobutamine, you see the heart rate increase, and you're doing echo simultaneously. You can see, is the ventricle normal, or are you inducing wall motion abnormalities? If you're inducing a wall motion abnormality, now you have your answer. If it's completely normal, now we can say, hey, you know what? We've done our risk stratification. We haven't given any radiation, and it's a win-win on all sides. So dobutamine stress is a good test. The other aspect is you may actually, if you're far enough out from the delivery, if the patient can go on a treadmill, plain treadmill, maybe actually a good place to start as well. So there are options there.
Excellent. Okay. And then we have a couple of questions here from Flavia Borges. Fantastic talk. Is there a way to build in cardiac PET CT orders in EPIC for HHS patients, also to facilitate to have the results?
Right. So thank you, Flavia. Unfortunately, because the two EPIC systems don't necessarily communicate with each other, for patients at St. Joe's, you simply type in Persantine and your only choice will be PT-CT, which stands for PET-CT. When you're at HHS, because there's a separation between the two EPICs, the best way to order a cardiac PET is simply use the paper rec. And so anyone needing a paper rec, I'm very happy to mail that out or email that to you. So feel free to email me if you ever in need.
Yeah, and I think Flavia has highlighted, kind of a common theme as it relates to certain tests or orders that are crossing the organization. So lots of room for improvement, and flagging that as something to add to the list. Thanks for your response there, Vikas. So we've got one more question. What is the cost of a PET exam compared to a MIBI one?
Absolutely. So, I think it's a very interesting question, which can be actually looked at from multiple ways. When we have a PET camera and we're running a PET program, the tracer that we use is ordered. It comes in a box, and that box lasts the whole month. So if you only do one cardiac PET, you've now paid, and I don't know the exact numbers, but you've paid now $10,000 for that box, and you've only done one PET. However, if you do 100 PETs, now you know that, okay, you've actually made it very cost effective. MIBI, when you're ordering it, you're ordering per dose. So there's 5 MIBIs scheduled. The lab is ordering 5 MIBIs. The cost of MIBI is, I'm guessing, roughly about $200 per dose of MIBI. And that's an estimate. I think it's probably about $200 to $300, somewhere in that range. So on a per scan basis, it really depends on volumes across each site. So for PET to be cost effective, it needs to be well used because you're ordering the tracer in a batch. Maybe as long as you're only ordering as much as you use, and so there's no wastage there, and so it's a per usage protocol. So that is from the angle of tracer, but the other angle is downstream testing. So if I order a treadmill, it comes out inconclusive, and my patient's BMI is, let's assume 45, and I decide to choose MIBI, and the MIBI now has attenuation artifact, and now I have to order a cath. Now I've ordered kind of 3 tests there. If the patient has the treadmill and it's inconclusive and I choose PET because the BMI was 45, I get a very clear, concise report where I know, okay, no further testing needs to be done. So there's that aspect of it, as well as appropriately choosing your patient based on BMI will help prevent downstream testing that may or may not need to be done. So there's that aspect of it as well.
That's great. Thank you so much. So much to consider when we think about cost. So there's one more question, and then we'll probably wrap up the session. Thank you, Vikas. Excellent overview of cardiac PET for risk stratification. You mentioned its use for bioprosthetic valve endocarditis. How does this compare to TEE? And with regards to native endocarditis, what is its sensitivity specificity?
Absolutely. So I think that's a great question. TEE obviously is going to be the workhorse here. So when you're considering endocarditis, whether it's native valve or bioprosthetic valve, the first step is actually do the TEE. If the vegetation and the endocarditis is obvious on the TE, then you actually don't need to go any further. Where the role of PET is where there's any degree of inconclusivity from your TE. So the valve looks kind of degenerated, but I don't see a clear vegetation. The annulus looks thick, but again, I don't see a periannular abscess. The TEE doesn't show any vegetation, but the cultures keep that coming back abnormal. Those sorts of situations would be where I would use the PET. In which cases it has, again, for this indication also sensitivity and specificity in the 90% range. So PET is one of those techniques where it's fantastic, but you want to keep it as the ace in your pocket so that when you're stuck, you can say, okay, you know what? We don't know what this is. Let's do a PET. And that way you're using it appropriately and using it to where it would be most helpful.
Excellent. Thank you. We got some thumbs up. So thank you again. Big virtual round of applause to Dr. Vikas Tandon for joining us today, for providing this excellent talk and really engaging Q&A. Thank you all for attending. Rounds will be back next Thursday with HHS as the host site, and it will be Dr. Paula Marquez presenting. The following week, February 29th, also HHS host site with a presenter from CMPA. so likely relevant to many of us. Following that, March 7th will be Chair's Medical Grand Rounds, and then on March 14th, there will be a break for March break. So wishing you all a wonderful day and week, and we'll see you back next week for rounds. Take care.
Thanks so much.